Welcome to this session today, guys, where we're going to be taking this opportunity to delve into some of the really important benefits that I feel obliged as a healthcare professional to be able to translate across some of the our most high value care options for helping almost anything, and that's going to be exercise and understanding. Now, this session could be it could be something that you're discussing with your healthcare professional at the outset before you engage in a program, or it could be a review and going back over some concepts at some point further down the line. And I'm going to start this session off with sharing a really helpful video of a chap called David Butler, who's a leading pain scientist and researcher from the NeuroScience Institute. They're a group out of Australia, and they're very much pioneers and leaders in communicating and understanding some of the important concepts around pain. So I'm going to share that in the video to start with, and then we're going to get into it and how it's going to be applicable to our program or your program after we've gone through some of these important points. So bear with me. The sound may not be perfect, but we should be able to get the key points across for when I bring you back in with me. Over to you, David.
Hello, my name's David Butler, and I'm going to tell you about a remarkable thing that we all have deep in our brains, a drug cabinet full of the most remarkable pain-killing chemicals. This little cabinet is deep in our brains. This is my picture of the brain here. We'll put a little bit of hair on here just to orientate yourselves. Deep in our brains, we have areas that work together to produce remarkable pain-killing drugs. I'll draw it as a box for you. And we'll put a big cross on it. Now, if I was to ask you to name the painkillers that you can buy from the pharmacy, you'd probably name Nurofen, Panadol, Panadine. You would also be aware that morphine is a powerful painkiller. But can you name the ones that your own brain makes? For example, you can make opioids like endorphins and enkephalins. You can make serotonin. Your brain can even make morphine. And it's a morphine that's much more powerful than mankind can make. And these are made in this remarkable drug cabinet. How does it work? Well, these chemicals are made and they trickle down the spinal cord. They also trickle up into the brain. Let's look at the spinal cord first. If these painkillers are trickling down into the spinal cord, then impulses coming in from the body telling your brain about warmth, cold, stretch, danger can be stopped at the spinal cord. It can stop any impulses coming up. Now that's a great system. That's a great system. So how do we close this drug cabinet? Well, the cabinet is under control from various areas up in the brain. And these areas in the brain talk to each other. They weigh up the situation of the world. We say they weigh the world. And they decide if it's worth opening up the drug cabinet. If it's open and the painkillers pour out, there'll be no pain. If it's closed, then impulses can come in and there will be pain. And of course, these areas of brain take their messages from the eyes, from the nose, and from the ears. But the key question the brain has to answer to work out whether it's opening up the drug cabinet is simply, is it worth making pain? Is it worth having pain? Is it worth pain? So let me give you some examples. If you run and stub your toe while crossing the road, and you have to get out of the way of a car, it often doesn't hurt. It might hurt when you get to the other side, but the brain's made a decision. It's not worth having pain now. Pain can wait. And what it will do will be simply to flow, and there'll be no pain. Or you may have heard of people finishing a sports event with a severe injury, but that person's decided it's important for me to finish this game, and therefore it's not worth having pain right now. In that example, open up the cabinet, flooded, and impulses get no further than the spinal cord. But it can go the other way too. If you put a pin in a violinist's finger, it hurts more than if you put a pin in a non-violinist's finger. Obviously, there's much more of a threat or challenge if you put it in a violinist's finger, and the brain will think, hey, it's worth having pain here. This needs protection. Let's close the box and have more pain. If you're scared about your back, if you're worried about your back, the x-ray doesn't look too good, someone has said you're in a bit of trouble, there's a lot of degeneration there, and you don't understand the meaning of pain, then the brain quite rightly would make a decision, it's worth having pain here. Protection is needed, and of course pain is one of the greatest protective things to make you change behaviour. But I should say, let's be grateful for the man-made drugs too, because at the right time and context they can help, particularly for acute pain or when there's inflammation happening. But the key thing is, for any man-made medication to work, it needs to kick in your own internal pain control system. If I was to sum this up, I'll do it with the key. What is the key to opening up the drug cabinet in the brain? To opening it up and flooding so we don't have pain all the time? Well, it's a understanding. It's having support. It's having knowledge. It's having achievable goals. In particular, it's knowledge. We say that knowledge is the greatest pain liberator of all, particularly knowledge of how your body works.
Thanks, David. And hopefully that has provoked some thoughts or some questions in your mind, because that's really what we're going to build on in this session, is to be able to make sure that we can try and tap into what we're using as a metaphor here as our internal drug cabinet in the brain. And there's multiple ways you can do that. If you've started learning and understanding more about pain, then this process is already happening. We've discussed, hopefully at this point, that we've introduced that pain is not a tissue damageometer, that it is an alarm system that can be set off by multiple different things. We've looked at examples, as David talked about, how we can have tissue damage and no pain. We can have pain and no tissue damage. Maybe we've thought about some examples around that, and we've looked at, started to discuss some plausible methods for how the nervous system can be turned up to protect us. And that can happen in our tissues, out in our skin, in our muscles, in our joints, and it can also happen in our central nervous system, and that's really from the spinal cord and up to our brain. And that's one of the mechanisms that we're talking about here. And we've talked about how pain is an output of the nervous system based on requirement. Is it appropriate to have pain now? Is it helpful? Is there credible evidence of safety versus threat? All of our nerves are connected like highways, and there's a little resting buzz in them that tells us that we are alive. And one of the biggest goals that we've talked about and we're trying to support you through here is to desensitize and calm your nervous system back down. So it's not overprotective, but it's able to warn you appropriately of dangers or potential dangers. Because we can have too much of a good thing. And David drew on a whiteboard there a nice little cartoon version of how understanding and how the internal drug cabinet might work. But if we were to take a cross section of your brain in an MRI scanner, so you're lying in an MRI scanner, you've got back pain, or you've got knee pain, or you've got shoulder pain, you've got a complaint, and we can scan across your head. So you don't need to be able to see exactly what or understand what this image is, but this line is one image. And what I want you to notice is just how nice and peaceful it is, compared to the next line, which is when you move your painful body part. Okay, so when you move your back, so for example, just some little pelvic tilts which are painful for you, or if your knee hurts, to be able to bend or twist your knee a little bit, and you get that pain experience whilst in an MRI scanner, what we see is the metabolic activity in all of the different regions of the brain that is associated with your pain experience. And that's also another really important point, is to illustrate the fact that it's not one part of the brain, it's all of our brain. So it's the part that controls our vision, the part that controls our memory, the part that controls our movement, the part that controls our sensation, and all of these will make up our own individual pain experience. And what this study illustrated was that that person then went through a similar set of contemporary pain discussions around separated tissue damage and pain, how different things can set off pain as a multifaceted experience, like the immune system, like temperature, like our emotions, like all of these different things, over 4 sessions. And then in the MRI scanner, they move the same painful body part again, and with much less threat around understanding that pain doesn't necessarily mean tissue damage, and we can confidently rule that out with our assessment, much less metabolic activity in the person's brain when moving that body part, which is a really nice tangible way to be able to see how, when people talk about how understanding and education around these things is a painkiller, is it literally is. And we can see that on an example from just 4 education sessions where this person didn't have exercise, they didn't have manual therapy, they didn't have the other things that we would put into a program, just showing that that understanding is an analgesic, or a painkiller. So all the work that you're doing to try and get onto the same wavelength with these concepts is really investment, and it is part of a really important part of your treatment. And one of the best measures that we try and use is if you can explain some of the things that you're going through to somebody else, because then we can understand it. And that's what we're really doing in that process, is trying to shift and desensitize our nervous system back to where we were maybe before we had pain, or before we had the complaint that we're currently experiencing. The next component that we can really draw upon to be able to try and desensitize your alarm system, and you've probably started doing it, or if you haven't, this is an important concept, because this is the idea how exercise can be a painkilling effect. And if you've ever done any running, if you've ever had a busy period of life and you've experienced that, going out for a run or going out for a walk and clearing your head and almost getting that euphoric feeling, that is what people will describe as the runner's high. And if you've never done any exercise or training, then it might sound like a novel concept, but there is a lot of neurophysiology to be able to explain this mechanism, tapping into that drug cabinet in the brain that David introduced at the start. And that's something that I want to be able to just illustrate, that there is some differences that seems to be around people who have not been experiencing long-term pain compared to people who do. And this is important because I'm going to pull up a piece of research here. Now, I know that research isn't very effective at changing behavior or influencing. But if I can make this relevant to you, this I think is a very important concept. Because as I illustrated there, if you've ever experienced what we call the runner's high, then you will know and will understand that that is a very tangible, real thing. And this research here that I'm putting up is a study that compared people who have had, people who've never experienced persistent pain and people who have had various different types of ongoing pain. So we've got the group on the left here, which is people who have had chronic low back pain, persistent low back pain, people who have had persistent neck pain, people who have chronic widespread pain. We've got people who have fibromyalgia, which is widespread pain, people with shoulder pain, people with osteoarthritis, and lots of different examples. And what we do here is to be able to then give a single bout of exercise. That could be simple as walking on a treadmill. It could be putting you on a cycle ergometer. It could be going swimming. It could be even resistance exercise. And that's what is in this column here. Is you'll see that this is going on a bike. This one is some reps of lateral shoulder raises for neck pain. And we can measure pain pressure threshold before and after doing a single bout of physical activity or exercise. And what happens in people who have never had pain before or people who have never had persistent pain will consistently show, which is what this column here is about, and this is the control people, so people compared against people who have persistent pain. And this arrow illustrates that after doing exercise, within 30 to 40 minutes, they experience every single one of these groups, no matter what type of exercise, whether it's aerobic exercise, resistance training, a reduced sensitivity to pain pressure threshold, which is where there's various ways that they can measure that, or we can measure that by putting an amount of pressure on your skin and asking you to be able to rate it as comparing it to a non-painful body part. Do a similar thing with an ice cube where you can report how cold it might be and compared to a non-painful body part. And across the board, all different types of exercise cause that, what we call exercise-induced hypoalgesia. So it gives you that bit of kicking in your internal drug cabinet in the brain. Give that same bout of exercise. So in this one here, for someone who's had chronic widespread pain, where they've gone on a cycle ergometer, and it was just incremental, so it gradually got up to about 75% heart rate, which they can measure on the pulses that you'd have in a normal gym or on your watch on a Fitbit for 5 minutes. Now, in people who have who are not experiencing pain or haven't been persistent pain, this causes a reduced sensitivity when they test afterwards. They have that drug cabinet kicking in, that runner's high as we describe it. The people who have had persistent pain have the same protocol and the complete opposite happens. It increases their sensitivity and otherwise it can flare a pain experience. And this is so important because across the board, when we look at these different groups of people, that you may fit one of them with chronic back pain, persistent neck pain, widespread pain, so you've got pain in lots of places, shoulder pain, osteoarthritis, so you may be experiencing knee pain. As I go through here, you'll see that the arrow for this column here, which is the people who are experiencing pain, the exercise bout makes their pain worse. And that's so important, because if that's not communicated to you, that's where people ultimately come to me, and they come to the healthcare professional, and they will perceive that exercise didn't work for them. They will perceive that rehabilitation just doesn't work because this wasn't explained as a mechanism that seems to be something dysfunctional about the internal drug cabinet of the brain and the spinal cord and our nervous system, as opposed to, I've got neck pain, and so let's look at this top one. I've got neck pain, and then I do some exercises for my shoulders, which is close to my neck, and then it flares my neck up. I'm perceiving that is now causing more damage in my shoulder, therefore I shouldn't do it. And that is such a travesty in terms of rehabilitation, because we have to be able to normalize and expect a bit of discomfort. And if we can't navigate and get through a potential flare, that people who have persistent pain is very likely to happen. And we need to be able to normalize that as a change in the nervous system rather than a measure of damage to your body part in question. Okay, and that's so important, and that's a point that I want to be able to get across here, is that it may well be that we are looking to change the central mechanisms of your nervous system. But something that is interesting and that I want to be able to get across is also how we do have research that shows that if you have a body part that is painful, we can still experience the runner's high by exercising another body part without making your painful body part worse. So there is research to show that we can still find and adapt exercise even if we do have our nervous system is protecting us in our attempts at trying to participate in physical activity. And that's super important, because there's something else that's really, really important that I want to pull out from this research in particular, is that the intensity of this type of the physical activity that you need to be doing does not have to be running a marathon. It doesn't have to be super high intensity training. A lot of people, you may not like exercise. So we have research to be able to show that if I was to give you a very prescriptive heart rate percentage and amount of sets and reps for you to go and do, compared to asking you to be able to say, what do you enjoy and how much do you want to do, in terms of stimulating this internal drug cabinet in the brain, there doesn't seem to be that much difference. What I do know is that if you choose it on your own, you don't have me standing over you to be able to say, "Oh, I'm pushing a little bit harder," is that you'll probably do less, but it doesn't really seem to make that much difference in terms of stimulating and getting the benefits to calming our nervous system down through exercise. Okay, so this is a really, really important point that I want to ensure that we get from the start, because when we're going to be engaging in exercise, especially if you've had pain for any period of time, it's likely that we will get a flare. But when the meaning of that is that, okay, that is, my shoulder's flared up doing this, I'm not causing more damage, I need to be able to navigate this flare up with my toolbox that we've been working on, and it makes sense that some of these changes might be happening centrally. And that's really what the rest of this session and our program is all about, is trying to desensitize the nervous system. Physical activity is one of our most powerful ways of doing so. And you're going to be spending a lot more time away from anyone, from your healthcare professional or from me. So being able to embody and really, truly embrace the idea that we can be sore but safe, that we can hurt, but it doesn't necessarily equal harm. Or another one I like to use is that ships are safest in the harbour, but that's not what they're designed to do. And that's going to really help us to be able to engage with the fact that we could get a little bit of a discomfort that we need to be able to navigate and work through. Which leads on to the next most challenging thing that I think, even when I have an awareness of these concepts, when I have pain and when you have pain, being able to establish and work with how to exercise and how much is too much, how much is not enough, is a really challenging trial and error process. Because some people will have a very old school, no pain, no gain attitude, where we've got, it's from my sporting background, particularly with my training. I've got my goals and I've got these sessions that are planned, and if I'm in pain, I've just got to carry on and get through because it's part of my training program, and ultimately my nervous system will end up stopping me until the pain stops, and then I wait for the pain to stop, and then I go and I crash really hard again. And this pattern is something that we call boom and bust, and that's where we just ignore pain and say no pain, no gain, and crack on and crash right through. This ultimately in the long term leads to us sensitizing the alarm, and it means that we are able to do less before our alarm starts protecting us. And as I said, I tend to see that a lot in myself, particularly around training. Other people I've worked with will find that they have families and they've got chores, like they've got to get the house done, and if they don't get it done, it'll just build up. And ultimately what I want you to do here is identify an activity that you may be able to identify a boom and bust pattern. So you can stop the video, and I'd like you to write it down, because that activity, which you may think of after this session or further down the line as you identify it, becomes something that we want to pace and we want to break down. Okay, so, but if you write it down, you identify it, that's the first step. The next strategy that a lot of people will often take will be the opposite, which is where we have a fear around causing or bringing on the pain. So we'll do the activity and then we will stop and we will back off because we don't want to cause ourselves that back pain again or the shoulder pain, and then we will do the activity again and then we'll back off, and we will do this over and over, but we will always be very hesitant about bringing on symptoms. And we call this fear avoidance, and this again over time ultimately leads to us being able to do less of the thing before we set off the alarm. And again, I want you to be able to stop the video here and write down anywhere in your pain experience up to this point you might have noticed this approach to things that are in your life. For example, I've had shoulder surgery and I've dislocated my shoulder, and going into an internal rotated overhead position gives me apprehension, and I'm pretty fearful of that position. So that position I tend to avoid, and if that was a position that was important for my training, then it would be one that I would identify that, okay, I'm pretty fearful around going overhead into this position, and okay, I'm appreciated, because these things we need to be able to start grading a way to work towards it, because otherwise we're not going to be able to undo the implications of doing it less. So if we've got two approaches, one is that we go no pain, no gain straight through. One is that we're fear avoidant. We want to try and strike this idea of the Goldilocks period in between, where we can engage with an amount of discomfort. So we could be working with a number out of 10, or we could say mild, moderate, or severe. With your healthcare professional, you need to be able to come up with some language that helps you engage with a certain amount of discomfort, not crash through, not back off, but touch it, nudge it, tease it. And that looks nice as a concept when it's written down, much more trial and error and practice and improvising our way through figuring out what that looks like in real life, because that's going to be for your activities that you enjoy, that we are going to be wanting to prescribe to you. So you enjoy, if you're turning around and you're saying, I really enjoy walking, I really enjoy cycling, I really enjoy climbing, or I really enjoy going down the park with my friend. Whatever those are, I'm going to want to prescribe to. That can be used as your aerobic activity. That could be part of your program. And if it's something that we're finding that we're getting a little bit of a flare up, we're going to be wanting to apply this idea of touch it, nudge it, tease it. Equally, we'll also be doing that with our approach to exercises that you may be doing with your healthcare professional as a more specific part of your program. Start with the least that we can, and then we slowly build. And then with this idea of touch it, nudge it, tease it, and being able to say, okay, I'm sore but safe. We've done the assessment, my joints and my nerves were all tested, they're all passed, and they're all okay. But in terms of structurally, over time, we can do a little bit more, working towards those goals and those things that are really meaningful for you to be able to get back doing. Some other things that David Butler mentioned in that video to help calm our nervous system down is to appreciate that we have an internal drug cabinet. They're morphine, all these really strong medications. They work because they stimulate and trigger the the internal cabinet that we have through endorphins. And that's where, if I want you to be able to, if you're having a flare-up day and it's a little bit sore, you know, take it to over-the-counter pain medication is completely fine, especially if it helps us work towards and doing the active things. That's really what we're trying to, the picture of this drug cabinet. You know, we're trying to turn on the drug cabinet to be able to flush and prevent excessive danger messages, because they're not pain messages. Remember, they're danger messages that could be coming from your sore body part. And if I was to ask you if you have ever stubbed your toe, just like David Butler said in the start of that video, you would probably say yes. You maybe stubbed it on the bottom of the stairs, etc. And if I was to ask you if it hurt, you'd probably also say yes. And if I asked you how long did it hurt, a week, for a month, for 6 months, you would probably say no, it only hurt for a minute, 2 minutes, maybe 5 minutes. Someone was watching, bang my toe. It makes sense. I can stimulate the internal drug cabinet in my brain to be able to prevent it becoming a persistent pain experience. And that's one of the really challenging things around aches and pains that have come on from nowhere. It makes much more sense when we fall out of a tree and we bang ourselves and we hurt after that point. It makes sense when, if you have an injury where you sprain your ankle and you've got all that tissue damage, that pain is associated with that. And that's why our nervous system increases the requirement for protection when pain comes out of nowhere, apparently nowhere. And that's what we need to be able to make sure that we can explain. Because as you saw on that table, when I took you through at the start, the people who have not normal, non-painful, not normal, but people who have not had persistent pain will have this high in terms of stimulation of the, or kicking in of the internal drug cabinet to be able to flush down these chemicals like endorphins and our endocannabinoid system, and in response to exercise. And we looked at that table. And we also looked at how people who have had persistent pain, which may be yourself, have often the opposite effect when we give exercise. And that means that we have an increased sensitivity and maybe even a flare-up. And that's one of the metaphors that I want to be able to use, is that our brain has become dry. We have lost the ability to flush down those chemicals for whatever reason, and there's lots of reasons that could be. And in this process of trying to tap into learning more about pain, trying to find the exercise that works for you, whether it's moving that painful body part or moving a distal body part, to be able to try and turn and shift our brain or our nervous system into a metaphorical wet brain, to be able to kick this drug cabinet back in. And we can do that, and that's what a nice broad holistic approach to this is going to help facilitate. And to this end, another really useful connection I want to make here for you is expectation, or another word for expectation that you may have heard battered around would be placebo. Now, placebo is positive expectation, whereby there is an enormous amount of evidence around, not just in pain, but in performance, around how people feel better when they expect to feel better. And that is a physiological mechanism that is tapping into this same internal drug cabinet as exercise and as learning. And that's one of the bases of being able to try and shift towards a positive expectation through this process, because the opposite of that is a negative expectation, which is nocebo. And it makes me, a story that made this connection for me was to look at curses. You know, if I was to curse you and condemn you to 7 years of bad luck, then you would leave, and guess what you're looking for? If I've told you, you're going to have 7 years of bad luck, what do you leave primed to be able to see? You're looking for bad things. What do you see? Bad things. And that's exactly the opposite of being able to appreciate how stimulating this neurophysiological, when we have this positive expectation, it does have a neurophysiological impact on these chemicals that can reduce pain. Placebo often gets a bad reputation because it's compared to a medical intervention. And it's really important if you have something that, like an inflammatory process like asthma, that you don't have placebo therapy. But if you have had medical causes of your pain, like we would have gone through at the start, pain is a human emotion, it's a human experience. So we want to be able to tap into all of the things, including expectation, including physical activity, including understanding, to be able to give our nervous system the best chance of being able to find the exercise and movement that we can engage in long term. And we understand that we could get a flare up, but it's often very reinforcing when we can get through that flare up and realize that the nervous system can be turned up and turned down, but your body part is still resilient and robust coming through the other side. And your healthcare professional should be able to really help tailor you towards those things that help you achieve that. Being able to look at some of the activities that you've written down there that you may be boom and bust, look at some of the activities that you may be fear avoidant of, because we want to break these ones down into smaller pieces. We want to find a way to start grading you towards the ones that you're fearful of, and to be able to get the benefits of aerobic or exercise or resistance exercise or exercise across the board, because exercise is true medicine. It's the closest thing to a health unicorn that we have, but we need to be able to adapt it to you and find the best way that it's going to work for you in your life. Okay, so I hope this has been helpful. This is something, one of the worst things that I can hear is when people say, I've tried exercise, tried rehab, and it didn't work for me. Whether we have depression, whether we're overweight, whether we have pain, whether we have cancer, exercise that is applied to you makes everything better. It doesn't cure everything, but it makes everything better. And it's definitely something that we need to be able to support you in, something that you can stick with through this program. I hope this was helpful, and we will continue working with these concepts next session.